hormonal contraception. Now, various hormones have been used throughout decades for contraceptive purpose. The main hormones that have been used are estrogen and progesterone. Now, to understand how the hormones work as contraceptives, you have to understand how the menstrual cycle is regulated normally, what we call the HPO axis or hypothalamo pituitary ovarian axis. See, the ovarian function is not independent by itself. Ovarian function is controlled by pituitary gland secretions, and this is again controlled by the hypothalamus in the brain. Now, what happens normally is the hypothalamus releases the releasing factors, what we call the GnRH or gonadotropin releasing factors. These factors then act on the anterior pituitary, and the anterior pituitary releases the gonadotropins, which are FSH and LH, that is follicular stimulating hormone and luteinizing hormone. Follicular stimulating hormone every month from the beginning of the menstrual cycle, it causes development of the Graafian follicle and the ovum within the Graafian follicle. Now, the function of the luteinizing hormone LH is that at the mid cycle, when the maximum development of the Graafian follicle has occurred, the ovum has reached its maturity, then this causes the release of the ovum. And the ovum is then picked up by the fimbrial end of the fallopian tube, and then the sperms reach the ovum in the fallopian tube and fertilization occurs. That is what occurs if pregnancy occurs. If pregnancy does not occur, then the Graafian follicle, after release of the ovum, becomes a corpus luteum and secretes progesterone. So the presence of progesterone means ovulation has occurred, ovum has been released. Remember, progesterone is not secreted by the Graafian follicle before ovulation occurs. So presence of progesterone means ovulation has occurred. So, in the beginning of the menstrual cycle, as a Graafian follicle is developing, this produces the estrogens, estradiol mainly, by the theca cells in the and the granulosa cells in the Graafian follicle. Now, after ovulation, when the Graafian follicle becomes a corpus luteum, the theca cells in the corpus luteum start producing the progesterone, and the progesterone increases in the midpoint of the secretory phase. Now, at the end of the menstrual cycle, if no pregnancy occurs, no implantation of the fertilized ovum occurs, then the corpus luteum also regresses, the estradiol and the progesterone secretions reduce, and then the patient has withdrawal bleeding, which we recognize as menstruation. See, all these various events are shown in this uh, uh, graph. You can see. See, this is the beginning of the menstrual cycle. This is the time of ovulation. You can see the days marked on the x-axis. This is the 14th day. This is the first day of the menstrual cycle. This is the 28th day of the menstrual cycle. This has been represented in a 28-day cycle woman. So, at the beginning of the menstrual cycle, because of the effect of the hypothalamic releasing factors, FSH is released, and this FSH, you can see the blue line, then FSH is increasing by the middle of the proliferative phase. Then, as FSH is increasing, you can see the estradiol in the lower one. The cursor is not working. Okay. The estradiol, the purple line, you can see that estradiol is going on increasing. And by mid-cycle, the maximum secretion of estradiol has occurred. Now, you can see the luteinizing hormone as the red line. In the beginning of the menstrual cycle, there is no luteinizing hormone secretion at all. Now, as the see, it is almost like a baseline level only. Now, in the mid-cycle, when the Graafian follicle development has occurred, there is a surge. There is a rapid increase in the secretion of LH. That is what we call LH surge. And then it is this time the ovulation occurs. Then after ovulation, the LH secretion falls down. By middle of the secretory phase, it reaches again almost the basal values. You can see this estradiol, which it has increased maximum in the mid cycle, and after that there's a slight fall with again a secondary rise. Now you can see the progesterone in the proliferative phase, progesterone is almost nil, and once the ovum is released, the corpus luteum starts secreting, and there is increase in the progesterone secretion. It reaches the maximum. By the end of the menstrual cycle, see, all the hormones have come to the baseline level, and then there is menstruation. This is what happens in a normal menstrual cycle. So now, which hormones are we using for contraception? Mainly estrogen and progesterone. Now, when the when these phasic increases and decreases of the hormones is not there, when we give exogenous hormones, there is a uniform level of these hormones in the blood. So what happens is, there is a negative feedback effect of these estrogens and progesterones on the pituitary and the hypothalamus. So as the you can see, as the estrogen levels are increasing, the FSH level has fallen. Why? Because these increasing estrogen levels have a negative effect on the pituitary and on the hypothalamus, and the release of these hormones from the pituitary and hypothalamus are reduced, so that further development of other follicles does not occur. Okay, so this principle is made use of in this hormones contraception. When a uniform basal level is maintained, there is a negative feedback effect, and the pituitary, FSH, and LH are not secreted. There is no LH surge. Graphene follicle does not develop. Ovulation does not occur. So pregnancy does not occur. This is the principle how the estrogen and progesterone are acting in preventing pregnancy. This is again the same thing you can see here. Right. Now, basically, hormonal contraception consists of combined oral pills. These are the most common contraceptives. Now, these contain estrogen and progesterone. The estrogen that is present in this is ethinyl estradiol. Most of the pills, what we call pills, lay people call them pills, OC pills we call them. The estrogen is ethinyl estradiol. In 99% of the preparations, it is ethinyl estradiol that is present, and the concentration is 20 micrograms or 30 micrograms. Very low dose. We call them low dose contraceptives. Now, progesterone can be different in different preparations. Basically, these progesterones are orally active 19 non-steroid derivatives. They may be norgestrel, norethisterone, bisogestrel, levonorgestrel, etc. Right. So, basically, how do these hormones act in preventing pregnancy? They prevent ovulation by suppression of pituitary FS and LH surge by negative feedback effect, what I have already explained to you. Then, progesterone also causes local effect on the endometrium. It causes atrophic changes in the endometrium. When low doses are given, they cause atrophic changes in the endometrium, and decidual development does not occur, and it is not suitable for implantation. Progesterone also makes cervical mucus thick, tenacious, and impenetrable by sperms. When I was talking about natural methods of contraception, I told you about the cervical mucus. The effect of estrogen on the mucus is that mucus becomes profuse, thin, watery, and stretchable. But the effect of progesterone is that it makes the mucus thick, tenacious, and like a plug. It becomes like a plug in the cervix, cervical canal. So this is not penetrated by the sperm. So upward movement of the sperms will be prevented. Then increased tubal motility also occurs because of these hormones, and the fertilized egg reaches the uterine cavity before the fertilized egg reaches the appropriate stage of development. Say usually when the fertilized egg is in the blastula stage, or blastomia stage, it is implanted. Now, when it reaches the uterus very early, and the endometrium is also not at the adequate level of development, then an implantation cannot occur. So, these are the various effects of the hormones in preventing pregnancy. You see here, you can see the various preparations. This is how the OC pill preparations, different preparations will be there. This is one more Yasmin. This contains ethinyl estradiol and drospirenone. Drospirenone is an anti-mineral corticoid. This is mainly used not only for contraception, for prevention of hirsutism also. That I will talk to you about later. Now, these pills, combined OC pills, not only prevent pregnancy, they also have other benefits, which is made use of. These other effects is made use of in treating certain diseases and conditions in the woman. Now, so what are all the benefits of these combined pills? One, it controls fertility. Then, second, it is useful in menorrhagia and polymenorrhea. I told you the progesterone causes atrophy of the endometrium, suppresses the endometrium. So, endometrial hyperplasia and cystic glandular hyperplasia of the endometrium are suppressed, prevented. So, menorrhagia is controlled. Polymenorrhea is corrected. What is polymenorrhea? Polymenorrhea is where more frequent menstruation is occurring. When the menstrual cycle is less than 21 days, we call it polymenorrhea. So when we are giving OC pills, we give for 21 days in the cycle with 1 week pill-free interval. So in this interval, patient has menstruation. So regularly, the patient will be having at a fixed time menstruation. So polymenorrhea is prevented. It relieves dysmenorrhea and premenstrual tension. See, normally dysmenorrhea, whether it's congestive dysmenorrhea or spasmodic dysmenorrhea, is because of ovulation. Even premenstrual tension is because of the progesterone, which are present when normal ovulation occurs. So, when ovulation does not occur, OC are preventing ovulation. When ovulation does not occur, dysmenorrhea and premenstrual tension are prevented. They are relieved, actually. Then, because reduced bleeding occurs, anemia is prevented. There is lowered incidence of benign breast neoplasia. Remember, benign breast disease, not malignant disease. The effect of hormones on malignancy is different. They may increase the malignancy. So, in a woman who is having breast cancer, we hesitate to prescribe ocipils. But if for benign breast neoplasia like fibrocystic disease, etc., some people use this for the treatment. There is reduced incidence of functional ovarian cysts, ovarian cancer, and uterine cancer. See, functional ovarian cysts are cysts of the Graafian follicle. Sometimes, when the ovum is not released, Graafian follicle goes on increasing and becomes a cyst, what we call a follicular cyst. Now, these cysts are prevented because the development of the Graafian follicle is prevented by the OCPs. So, functional ovarian cysts can be treated by giving OCPs for about 3 to 4 months. Then, it has been seen in various studies that ovarian cancer is prevented by use of OCPs. If a woman uses OCPs, say for a period of 5 years, even after stopping the use of the OC pills, for 10 to 20 years, she is protected from developing ovarian cancer. That's a very big benefit. Ovarian cancer incidence will be prevented in that woman. Then, yes, uterine cancer is also less. Why? Because OC pills suppress the endometrium. There is no endometrial hyperplasia. See, normally there may be endometrial hyperplasia, then adenomatous hyperplasia, complex endometrial hyperplasia, which may further lead to endometrial cancer. Now, when there is no endometrial hyperplasia itself, so the incidence of endometrial cancer is also less in people using OC pills. The incidence of pelvic inflammatory disease is reduced. Why? Because the cervical mucus is very thick. It prevents not only the ascent of the sperms, it also prevents the organisms, bacteria, and viruses from entering in the uterine cavity. So, inflammation is reduced, PID is reduced. Ectopic pregnancy is reduced. Why? Because one reason is because there is no ovulation. The second reason is there is no PID, and so the tubal blocks do not occur, and so ectopic pregnancy does not occur. Then it is useful in the treatment of acne, PCOD, and endometriosis. Acne is because of normally excess of hormones like estrogens. So when we give these pills, there is no ovulation, no release of excess of hormones, so acne will be treated. Then PCOD, polycystic ovarian disease, is the condition where multiple follicles are developing in the ovary without the development of any single mature follicle. And these follicles go on producing excess of estrogens and androgens. Now, these androgens cause development of acne and hirsutism. So, in PCOD, these OC pills are used for about 3 to 6 months. Now, these because the OC pills suppress the development of the follicles, there is no production of androgens, and so the symptoms of this PCOD are relayed. Endometriosis. What is endometriosis? Presence of ectopic endometrium in a place other than the uterine cavity. This endometrium may be present on the ovarian surface, on the tubal surface, in the pelvic peritoneum, on the uterosacral ligaments, McEnroe's ligaments, etc. Now, this ectopic endometrium, every month, it also takes part in the development of the in the menstrual cycle. So, little amount of hypertrophy, bleeding may occur in these endometriotic sites. Now, when we are giving OC pills, since the endometrium is suppressed, these endometriotic cysts also are suppressed, and ultimately the patient is relieved from the symptoms of the disease. Then, it has been found that OC pills are useful in the treatment of anorectal cancer and also in the treatment of rheumatoid arthritis. These are all non-gynecological conditions. So, OC pills have multiple uses and they have been extensively used. Since any method has also got some side effects, what are the side effects of these hormones? They are not innocuous, they are not innocent. They do have side effects, though they are useful, they can have some deleterious effects also. So you should know in detail about this so that you will decide which patient you can prescribe OC pills and which patient you should avoid prescribing OC pills. So, what are the side effects? Sometimes intermenstrual spotting can occur, particularly in the first 2 to 3 months, till the body gets adjusted to these hormones, and later it stops gradually. This is only because of the upsets in the hormone levels in the blood. Yes. Then scanty menstruation and post-pill amenorrhea. I told you the endometrium is suppressed, so the menstruation is reduced, and sometimes it is reduced to such an extent that patient will have complete amenorrhea also, what we call a post-pill amenorrhea. But usually the patient will get back her periods once she stops using the pills. Monilial vaginitis. It has been seen that candidal vaginitis, that is fungal infection of the vagina, is very common in patients using OC pills. So if a woman has monilial vaginitis, it has to be treated and then only she can have use the pills. Cervical dysplasia. That is, it has an effect on the endocervix, not on the ectocervix. You know, ectocervical cancers are squamous carcinomas, which are because of the HPV infection. Whereas endocervical dysplasias can occur because of the hormones and on prolonged use. So these dysplasias have been seen to go into endocervical cancer on prolonged use. Yes, there is no effect on uterine fibroids because what we use estrogens, though fibroids depend on production of estrogens, what we use estrogens are very small amounts in these OC pills, so there is no effect. And as I told you before, breast cancer, the role is not clear, so we avoid OC pills in patients with breast cancer. Pituitary adenomas, again, the role is not clear. Lactation is suppressed. It is notoriously, the ossicles are notorious to suppress breast milk production. So lactation is suppressed. That is why in a woman who is lactating, who delivered recently and is lactating and feeding the baby, OC pills should be avoided. That is, combined OC pills should be avoided. Progesterone only OC pills can be used in such patients. I will talk about progesterone only pills later. Yes. Then nausea and vomiting because of the estrogens. Then benign liver adenomas, rupture of hepatomas have been described, though not common. So usually we avoid OC pills if the woman has chronic liver disorders or she has had a recent jaundice. Gallbladder function is also affected. Motility is slowed down of the bile duct. Yes, then because of progesterone, headache, migraine, depression, and irritability have been seen as a side effect of progesterone. Carbohydrate tolerance is reduced. That means if these hormones can increase, can cause hyperglycemia. So, in an untreated diabetic woman where the control of the diabetes is not good, not adequate, OC pills should be avoided. It has been seen that estrogens increase HDL, which is actually good. Increase HDL is good for a person, but it also uh, red and reduces LDL. But the progesterones have the opposite effect. That is, progesterones increase LDL, which is not ideal. Then, people who are taking treatment for other diseases, like say a patient with tuberculosis is taking anti-tuberculous drugs like rifamycin, or patient has some infection and taking any antibiotic like tetracycline, cephalosporins, or patient receiving antifungals, or patient with taking anticonvulsants like phenytoin, etc. All these patients, in these patients, the absorption of uh, these drugs is not good. That is, there is increased degradation of these OC pills in these patients. So, what happens if these people are taking this? If these people on the OC pills, the effectiveness of the OC pills is lost, and so they may conceive, and then they will say the method has failed. So, in these patients, you have to caution them and probably advise them some other method of contraception. Then, in patients with sickle cell anemia, thrombosis and crisis can occur because estrogens in the OC pills are notorious to cause venous thrombosis, and when thrombosis occurs, a sickle cell crisis will be precipitated, and the blockage and necrosis of the various organs, various tissues can occur. So, these are not good for sickle cell anemia patients. And because it is not barrier contraception, there is no protection against HIV and STDs, and there is no effect on thyroid function. Now, the most important and one dangerous effect estrogens can have is these OCPs can have is thromboembolic disorders. Estrogens can increase clotting factors, they increase fibrinogen, they increase platelet aggregation, and at the same time they reduce fibrinolysis. So, all the factors which increase clotting in the blood are stimulated, and at the same time, lysis of the clots that form is not occurring. So, what happens? The thrombus remains there, and then this thrombus can get dislodged and go in the bloodstream, go to the various organs like brain and the lungs, and cause embolism. So, pulmonary embolism can occur, cerebral embolism can occur, cerebral thrombosis can occur. All these are 7 to 10 times more in patients using OC pills. So, very high risk, and the risk is higher with desogestrel and gestodin containing OC pills. So, OC pills should not be advised if the woman has a history of thromboembolic disorders like DVT, deep vein thrombosis. Now, then, because edema can occur in the conjunctiva, people using contact lenses, the lens will not fit properly, and so irritation of the eyes can occur. And sometimes thrombosis of the optic vessel also can occur, and the vision can be affected. So all these are the various side effects of the OC pills. So from these various side effects, you can say you, which patient these OC pills are contraindicated. So they are contraindicated in patients with hypertension, by patients with cardiac disease, in smokers over 35 years, because vasoconstriction can occur in these patients. Then patients with diabetes, with history of migraine, sickle cell anemia, thrombosis, myocardial infarction, chronic liver diseases, breast cancer. All these are what I have already told you in the side effects. Then gross obesity, because obese people have also carbohydrate intolerance. And then patients using drugs like rifamycin, sodium valproate, etc. Lactating women, women with monival vaginitis, and 4 to 6 weeks prior to planned surgery. That is, a woman is planning surgery for some other condition. It may be a non-gynecological condition, some other condition she is going through, she has to go through some surgery. In these women, particularly if she has a tendency for thromboembolism, 4 to 6 weeks prior to the surgery, the OC pills should be stopped. Why? Because many times after surgery, in the post-operative period, lower limb thrombosis can occur, what we call DVT, deep vein thrombosis can occur, And if she is also using OC pills, this DDT in the postoperative period high incidence. To avoid that, we have to stop the pills prior to surgery. So, you know which patient you have to prescribe, which patient you cannot prescribe. So, how will you select which patient you are going to prescribe? So, most suited for which patients, young adolescents who are in unstable relationships. Yes. Then recently married women want to avoid the first pregnancy, and because married women recently nulliparous, we do not insert IUCD. We usually avoid IUCD. Last class I have told you that. Then natural methods are not that dependable. Barrier methods they are not willing to use. Then such a couple you can advise OC pills. Women desirous of spacing pregnancies. One pregnancy, she had one child, she wants to postpone pregnancy. Then women with also other diseases, because double benefit will be there. Those diseases also will be treated when she uses these contraceptives. So women with endometriosis, with acne, menorrhagia, polymenorrhea, dysmenorrhea, then postpartum or post-abortal contraception, it can be used. Women with PCOD, if there is family history of ovarian cancer, it can be familial also. So if family history is there in the mother or in a sibling, then it will be ideal to treat this patient, to put this patient on OC pills for contraception. Then women with recurrent functional ovarian cysts, then perimenopausal women, just to tide over a few, instead of doing a sterilization for a few months, she can use the OC pills. Then she will attain menopause and then she won't become pregnant anymore. So all these people are the ideal candidates for using OC pills. So before you prescribing OC pills, you can't. Patient comes, you can't just write down the prescription and send the patient. You have to examine the patient. You have to do some investigations and decide whether this patient is suitable for OC pills. So when the patient comes, you do a workup. You document personal history. You take family history, personal history, diabetes, hypertension, any history of DVT, etc. Or if she is having some other disease or she is wearing some other medications, all this history you must take. Family history of any, particularly any malignancies you can take. Then you record the weight, see the blood pressure, do a physical examination, particularly breast examination for any tumors in the breast, do a pelvic examination for any other pelvic pathology, do a pap smear at the first examination, of course you repeat annually. If the woman is over 35 years and also has a family history of breast cancer, rule out any breast malignancies, do a mammography. Then you investigations, complete blood picture, lipid profile, fasting and post blood sugar. You want to rule out other conditions like carbohydrate intolerance, diabetes, hypertensions, etc. Now, then you prescribe. When do you start the pills? You just can't. The patient comes anytime. You cannot prescribe because no point in prescribing in the mid of the menstrual cycle, isn't it? So it has to be prescribed at the appropriate time. Suppose a woman had a first trimester abortion. She has come, she was bleeding, we have done an evacuation, it was an abortion. Then immediately you can prescribe. The very next day, she can start taking the OC pills. Then, suppose it was a second trimester abortion, say the gestation age was 13 to 28 weeks. Then you wait for 1 week for all the pregnancy changes to come down. After 1 week, she can start taking the OC pills. Suppose she had a recent delivery, you can start after 6 to 8 weeks because in 6 to 8 weeks, all the pregnancy changes after a normal delivery will subside. Now, but remember here, if she is lactating, you cannot prescribe combined pills. So here you have to prescribe only progesterone only pills. Yes. Then, suppose she is a regularly menstruating woman, then on the first day of the menstrual cycle, you tell her to start the pack. That is, the first tablet must be taken on the first day of the menstrual cycle. Now, each pack has 21 tablets. The pill should be taken at the same time every day, one pill every day. See, she cannot take one day in the morning time and one day in the night time. No, because if she takes only at the regular time, a uniform level of the hormones in the blood can be maintained, which will help in preventing ovulation. If the hormone levels are getting upset frequently, then ovulation will occur and the method will fail. Then follow up after 3 months, and then later every year you have to follow up the patient. And you must give the patient information about what complications she can develop, and so that she can report immediately if she develops any complication. Right. Now, many times, see, these people, they have to take the woman has to take a pill every day. Remember and take a pill every day. So once she gets into the habit of taking the pill, say in the morning time, every day after breakfast or before breakfast, she's taking the pill, or every day after dinner or before dinner, she's taking the pill. If she keeps a fixed time, she will not forget to take. But sometimes she can forget. We are all human beings, isn't it? She can forget taking the tablets. So then she gets worried. What has happened? Is the method going to fail? Or is it still effective? Should I continue the taking the tablets or not? What advice you will give the patient? So in case of missing pills, what will you tell? Now, if one pill is missed, she has forgotten to take pill on one day. Then the next day, whenever she remembers, she can take that pill, and also the pill which she takes at the usual time. Or she can take both the pills, the previous day's pill and that day's pill, at the usual time that she takes. Now, suppose she has forgotten for 2 days, then she can take the two pills as soon as she remembers, and also she can continue the pill pack as usual, so that the regularity of the menstrual cycle is maintained. But remember, if she has forgotten for 2 days, two pills are missed, then the method may not be effective that month. So she has to use additional backup protection, like any other method, any temporary method. I was telling you when I was talking about barrier contraception, they can use for that month, they can use a barrier contraception like a condom or a diaphragm. But to maintain the continuity of the cycle, the pill pack has to be continued. Yes. Suppose 3 pills are missed, 3 continuous days she has forgotten to take the pills, then it is useless to continue the pack. Why? Because the irregularity of the menstrual cycle will occur. And also the method is will fail. It is not going to be effective. So what they must do is use some other backup contraception to prevent pregnancy, like barrier contraception. And also she must abandon that pack, whatever pack she was using, abandon that pack and start again with a fresh new pack as if it's a fresh new cycle. Okay. But also caution the woman that she can have some spotting and bleeding may occur, and also the menstrual schedule will alter because again she's starting a new pack. See, all this may appear why small things, but actually to the patient it causes a lot of confusion and lot of worry. So all this counseling must be done when you prescribe OC pills to a woman. Right. Sometimes we may have to change the ossicles. Now, when do we need to change the ossicles? When the woman develops some side effects like irregular bleeding or nausea, vomiting, or headache, migraine, any side effects she's developed, and she's unable to tolerate the side effects, then you change the pill to another preparation. A pill which contains another progesterone, or a pill which contains less estrogen or less progesterone, like that. You change to another pill. Suppose the symptoms of estrogen excess are there, like nausea, vomiting, edema, these are more. Then you change to a pill with a lower estrogen content or a pill with higher progesterone content. Okay. Suppose a woman has atrophic vaginitis, that is dry vagina, they're complaining of dyspareunia, then see, atrophic vaginitis may be because of less estrogen. See, to maintain the health of the vaginal mucous membrane, estrogen is responsible. Now, if the estrogen level is very low, she will develop atrophic vaginitis. So you change to a pill with higher estrogen content. Then, suppose she is having spotting in the first half of the menstrual cycle. Then you change to another OC pill, or to a pill with another progesterone, or to a pill with higher estrogen or higher progesterone. Okay, you simply change to another brand also. That also may help. If mid-cycle spotting is there, exactly the mid-cycle at around the time of ovulation in a normal menstrual cycle, then you change to a triphasic pill. Now, what is a triphasic pill? Triphasic combined pills are their combination of estrogen and LNG, that is levonorgestrel. But here there is no fixed dosage. Say the usual OC pills that what we usually prescribe are fixed estrogen and fixed LNG or any other progesterone content. But here this combination is made in such a way that in different days of the menstrual cycle, different amounts of estrogen and progesterone are present. So in the first 6 days of the cycle, 30 micrograms of ethinyl estradiol and 50 micrograms of LNG is present. In the next 5 days, estrogen content is more, the combination is increasing, the hormone content is increasing. 40 micrograms of ethinyl estradiol and 75 micrograms of LNG. And the next 10 days, 30 micrograms of ethinyl estradiol and 125 micrograms of LNG. So, and then for this is for 3 weeks, almost 3 weeks. Then the next week there is no medication. During this time, patient will have menstrual bleeding. So the whole purpose of these triphasic pills is that it mimics a little more like a normal menstrual cycle where the hormone levels are varying in different uh, phases of the menstrual cycle. At the same time, the pregnancy is prevented by preventing ovulation. That is the idea of this triphasic pills. Now, you got other types of oral pills. 3 monthly course oral pills are there. What we call seasonal LE actually. Now, seasonal is the trade name actually. Now, these pills they're same as the estrogen and progesterone containing pills only, the usual pills only, but instead of 21 tablets, 84 tablets are there, so that the patient takes every day one tablet for 84 days. So she will have an amenorrhea for almost 3 months. That means this is a 3 monthly course. So at the end of this 84 tablets, then she'll have withdrawal bleeding. So she'll be having only 4 menstrual cycles per year. Some people prefer this, and they find it convenient to have only less menstrual bleeding and less menstrual cycles to bother about. So this is one way of giving this medication. Then you got once a month pill, which contains 3 milligrams fenestrol. Fenestrol is the estrogen, and 12 milligrams of megestrol acetate. Only taking once pill per month is enough, but this is not very popular because failure rate is a little more. Then you got pills containing ethinyl estradiol and drospirenone. That is, drospirenone is an analog of spironone. That is, it is an anti-mineral corticoid. The purpose of giving drospirenone is that it has anti-androgenic activity. So, in patients with acne and hirsutism, that is, patients with PCOD, mainly we use it for the treatment of PCOD, where the woman not only has to be treated for PCOD, also needs contraception. Then this is given. What I have already shown the picture, Yasmin, those tablets. Now, this reduces the hirsutism by anti-androgenic activity. It because there is no fluid retention also prevents obesity also. Then there is a preparation called Dianate, which contains ethinyl estradiol and cyproterone acetate. This cyproterone is also an anti-androgenic. This is also used for the treatment of PCOD, where hirsutism is present. You can say these are the Yasmin tablets. This is Dianate. These are all only the trade names, what I'm showing in the packs. Now, we have got preparations containing only progesterones. Now, only progesterones can be given in some patients where estrogens are contraindicated. Now, these are available. The way you can give the progesterone is multiple. The route of administration you can give in a variety of ways. That is the advantage of these progestrogens. Now, you can give orally as oral pills. You can give as intramuscular injections. You can give as implants. Implants, that is silastic rods, which contain the hormones, are implanted subdermally into the skin. And every day, some amount of hormone is released from these implants. Then you can give as patches. Patches are just patches which are stuck on the skin, anywhere on the body skin, and then from the patch, a small amount of hormone is released every day. Then you can give as a vaginal ring which is impregnated with the hormone. Again, a small amount of hormone is released every day from the vaginal ring. Then IUCD, impregnated IUCD, which I have already told you in my last class, Mirena IUCD. So you can see the progesterones you can give in various ways. Now, the first one is a mini pill, what we call POP or progesterone only pill. The advantage is that the side effects of estrogen, like water retention, carbohydrate metabolism, then thromboembolism, nausea, vomiting, etc. All these side effects of estrogen you can avoid by giving this progesterone only pill. Now, this contains different preparations contain different progesterones, norethistérone 350 micrograms or norgestrel 75 micrograms or levonorgestrel 30 micrograms. Now, the way you give these tablets is again similar to giving OC pills, but you can start within 5 to 7 days after menstruation. One tablet every day for 21 days. Then, after 21 days, you stop the medication and then the patient has withdrawal bleeding. Then, if she's had a recent delivery or an abortion, you start 21 days after the delivery. One tablet every day. The same rules follow what I have told for OC pills. It should be taken at the same time every day without forgetting the tablets. Now, what are the advantages of giving this OC? I mean, pills which contain only progesterone. So they are useful women with lactation. So I told you, lactating women combine OC pills. They reduce lactation. How do they reduce lactation? By affecting the pituitary secretion of prolactin. See, for maintenance of lactation, continuous secretion of prolactin from the pituitary gland is very important. By suppressing, by negative feedback effect, these hormones, the hormones in the OC pills, particularly the estrogen, suppresses the prolactin secretion from the pituitary gland, so milk production will be reduced. So, in these lactating women, you can give the progesterone only pills. Then, women over 35 years, because 35 over 35 years multiple problems will be there, like hypertension, diabetes, carbohydrate intolerance, etc. Then smokers where vasoconstriction it is there, it is atherosclerosis is there, all this will be magnified by the combined pills. So progesterone only pills can be used in these people. Then women with migraine, women who are intolerant to estrogen, where estrogen is contraindicated in diabetics, in hypertensive patients, in sickle cell anemia patients, then patients using other medication I told you. Now, what are the disadvantages of the progesterone pills? They can have irregular bleeding. The woman can have irregular bleeding because you're not giving estrogen, you're giving only progesterone. Sometimes the control of the endometrium, control of the menstrual cycle may not be adequate. So, irregular bleeding, that is spotting, withdrawal bleeding can occur. Then amenorrhea can occur, like OC pills, continuous amenorrhea can occur. Depression, headache, all these are the effects of progesterone. Sometimes weight gain, not common, but weight gain is more with estrogen actually. Then ectopic pregnancy can occur if, because progesterone by themselves, they do not suppress is ovulation in all the patients. So the effect of progesterone in preventive pregnancy is by affecting the tubal motility, by suppressing the endometrium locally, and by thickening the cervical mucus and forming a cervical plug and preventing sperm's entry. So, but only certain preparations occasionally can prevent ovulation. Usually, it is not prevented by the progesterone only pills. So, ovulation can occur, sometimes pregnancy can occur, and because tubal motility is affected, slow movement of the fertilized ovum can occur, and ectopic pregnancy can result. Yes, then failure rate is more with progesterone only pills. Pregnancy rate is about 2 to 3 per 100 women years, whereas with OC pills it is zero point 0.1 to 0.2 per 100 women years. See, it is 10 to 20 times more with progesterone only pills. So, but still they have their usefulness in that in patients where estrogens are contraindicated, this can be used. Now, what are the contraindications? If previous ectopic pregnancy is there, patients with ovarian cyst, breast cancer, genital cancer, abnormal vaginal bleeding, active liver disease, porphyria, and along with drugs like other drugs, what I have already told you. Okay, I'll continue in the next class.